So yeah, just what we are speaking of, and this is as per the latest ASA guidelines, which were published early this year, right? So this is a clinical situation, anticipated or unanticipated difficulty or failure, right? Is experienced by a physician trained in anesthesia, limited but not included to one of these following technical problems, right? So either difficulty in face mask ventilation, laryngoscopy, suprachoroidal airway ventilation, intubation, extubation, or insertion of an invasive airway. So all these things constitute a difficult airway. Okay, so again, if you see this, these focus is on all the technical things that we do when we sort of manage the airway or intubate a patient. Okay, so now if you look at the consequences of a difficult airway, I think one of the best papers which everyone should be aware of is what we call as a NAP4 project, right? The fourth National Audit Project report, which was which was reported in 2011, was performed a couple of years before that. And they looked at the incidence of major complications of airway management during anesthesia in all of the UK. And these were airway disasters which were reported. And 184 reports came from OT, they came from emergency department and ICU, and 133 were related to general anesthesia. So they found that the incidence of difficult airway was 1 in 22,000 anesthetics, right? So 1 in 22,000 anesthetics were difficult, and anesthesia events led to 16 deaths and 3 episodes of permanent brain damage. So the mortality rate was 1 in 180,000, which was not bad, but still not good for those 1 in 180,000 anesthetics. But very importantly, they found that the elements of care were poor in 75% of these deaths or brain damage. So in other words, a lot of them could have probably been avoided had we looked after the patients better, had we done things better. And only in 3 patients, the airway management was considered good. So maybe there were some underlying conditions which were not sort of reversible, and in which death occurred in spite of good management on the part of the anesthesia team. So I think it's very important that we understand that we must do better if we have to prevent airway disasters. Now, and one of the problems, at least ever since I was in training many years ago, is we never had a sort of strategy or a plan on managing the unexpected difficult airway. So you try to intubate, and you just go on and on and on intubating. So you never had a good plan B. When I was training, we never had laryngeal masks. They came a little later in India, right? But then there were other options which we rarely ever exercised. So essentially, it meant that you kept on trying to intubate, or you got someone else who also kept on trying to intubate, and you never really had a strategy, and that would could sometimes lead to a problem, right? Someone, of course, could eventually intubate, but you could not be sure of what the outcome might be. So now the focus has now shifted on, you may want to intubate initially, but if you can't, or if you're having difficulty, you need to quickly switch to the next steps. And then you can sort of, and those steps will include going all the way up to a surgical airway for a cannot ventilate, cannot intubate situation, right? And the focus again is to maintain ventilation and oxygenation. So this is what has changed in the last, say, 30 odd years in airway management. Now, one of the first things is, can you predict a difficult airway? Because if you can predict a difficult airway, then you can plan much better, and you can focus your attention on those difficult cases which you have predicted. And I'm not going to go into all the sort of different mnemonics, you've heard of bones and lemons and rods and all those kind of things. But essentially, we've got a series of sort of tests that we do, isn't it? You looked at a hyomental distance, you look at retrognathia, you like the Malampatti score, you got a thyromental distance. You have an integrated score called the Wilson score, which looks at combines articles. Now, if you look at all of these, they don't have, what the key number here is, apart from sensitivity and specificity, is a likelihood ratio. And this should be more than 10. So if it is more than 10, then it's sort of, the test is a good test. It predicts difficult intubation. All of these have likelihood ratios of less than 10. And essentially it means that, they don't really help in very reliably sorting out a patient who is likely to have a difficult airway from someone who's not likely to have a difficult airway. In other words, the test may predict that this airway is not going to be difficult, but it could still be difficult. It could predict it's difficult, but it will end up not being difficulty. So many of the tests which we commonly do, we do them, and I think we should continue to do them because it does warn you a certain amount of cases. But these tests are not the God's truth, and you need to be very careful when you sort of with every patient rather than try and focus only on a few patients. Now, this was a interesting article which I came across some years ago, and they looked at all the tests that were reported in literature, including the Malampatti score, the modified Malampatti test, the Wilson score, and all these. And what they found was the upper lip bite test was probably the strongest test. It had a likelihood ratio of 14. In other words, it was a strong predictor of a difficult airway. The sensitivity was low. It was only 60%. That means you'd only pick up 60% of the difficult intubations. But if it was positive, the specificity was very high. If the upper lip bite test was positive, then in 96% of times your intubation would be difficult. And it's just how you can approximate your lower teeth to the upper lip. And the less you can do, and here you can't move your teeth up at all toward the lower teeth towards the upper lip. And here you can only partially occlude the upper lip. And here, right? So this is a normal test, and these are increasingly difficult intubations. So this seems to be one of the tests which was interesting to me because it was not something I was doing routinely, but maybe it's something we should adopt in our practice. Okay, so no clinical finding reliably excludes a difficult intubation, and the upper lip bite test probably is a little better than many other tests. Okay, but despite the fact that we don't have very good tests, I think we should assess the airway in all patients. It makes us think about the airway, and that we must have a clear idea of what we are going to do if it's going to be positive. But you need to know that even if the test is negative, your airway management may still be difficult, and you need to be prepared for every case that you want to do an intubation. You need to be prepared for a difficult airway. I think that is the bottom line. Now, there are many approaches to management of the unanticipated difficult airway. Initially, I will talk on the unanticipated difficult airway because that's where patients sort of do badly. So one of the most popular sort of algorithms or guidelines is the DAS, or the Difficult Airway Society of the UK algorithm. Okay, and what they have is they start with the plan A, which is the initial tracheal intubation, right? If it fails, then you go to plan B, which is your next plan, which is introducing a laryngeal mask or a supraortic airway device. If you can't ventilate through the plan B, through a laryngeal mask, then you go to plan C, which is to go back to a face mask and try and ventilate. And then if that also doesn't work, you go to a plan D, which is rescue techniques. And they call it a cannot intubate, cannot ventilate situation. And there, you can go to a surgical access, which is cannula cricothyrotomy or surgical cricothyrotomy. And then there are options if you can't do any of these. Now, here, this word, failed oxygenation, is a key word which they use here. But to me, that is a problem. A lot of people think that failed oxygenation means you have to wait for the oxygen saturation to fall or hypoxia to start coming in, and you start acting only when the oxygenation drops. But that's not the point. You have to prevent oxygenation from dropping. So even if your oxygen is okay, if you failed in this step, you should go quickly to the next step. I think that's what we need to understand overall. And this is sort of more detailed breakdown of the Difficult Airway Society algorithm. Is your initial is tracheal intubation. First, of course, if you have any problems, you call for help, which is good. And then you do sort of all these things over here. And I'll discuss it in little detail when we talk of the Indian guidelines. Okay. Now they say not more than 4 attempts, okay, at intubation. Okay, then you fail intubation, you go to a second plan, which is the supraortic airway, intubating laryngeal, mask, or laryngeal, and not more than 2 attempts. Okay, if you succeed, you need to verify tracheal intubation with a capnograph. Okay, and again, it's failed oxygenation. That is, now here, they say if the SpO2 is less than 90% with FiO2 100%, that means you're looking at serious hypoxia, and then you're going to the next step, right, which is a bit of a problem. Okay. the recently published ASA difficult airway algorithm is, it's got all these limbs here and there and a little difficult to follow, but this is their sort of classification. Okay. And again, here they limit attempts. They don't say how many attempts if you fail to intubate at anesthesia. Then you check whether you can continue to ventilate by mask, in which case it's a non-emergency pathway. If the ventilation is not adequate, you go to an emergency pathway, which includes a sporadic airway, and then uh, and then finally a surgical airway. So it gives you a sort of similar pathway, and this is medical legally very correct. So it gives you lots of options so that no one can be sued for missing one of the other. So if you read the actual article, at each step you can do 10 or 20 things. So it's a little complicated. Okay, but this is a diagram which they have, is that the pre-oxygenate induce, if it's successful, continue. If it's not, then you call for help. And then if you can ventilate, it's a non-emergency pathway, and then you use alternate devices, invasive airway or awaken patient if it's possible. And then there's an emergency pathway where you have a supraglottic or a face mask or a tracheal tube, and finally an emergency invasive airway. Right. Again, it's an article which you should read and be aware of. But this is all a little from the American Society. But what I'm going to speak about and what we follow are guidelines from the All India Difficult Airway Association, and these are what we call as the Indian guidelines for difficult airway management, which are also very good, and they were published in 2016 December and are going to be updated pretty soon. Okay, so now before I go on to the guidelines per se, and many of these concepts are there in the write-up of the guidelines, why do we get into trouble with intubation or airway management? So we start. If you see, when you routinely do a case, you pre-oxygenate the patient, then you induce anesthesia, you give propofol or something, then you give a muscle relaxant, and you create apnea, right? And this creation of apnea is done to make life easy for us so that we can do a intubation with the patient anesthetized, with the muscles relaxed, so we can, and the cord's not moving, so we can do the intubation nicely, without the patient coughing, bucking. So in other words, we are creating this situation to help us intubate the patient easily, right? So this creation of apnea to make our life simple actually is the crux of the problem. If the patient had been breathing spontaneously with oxygen all through, and for example, you had a method by which you could put a tube in very easily without the patient coughing or bucking, that would have been 100 times safer. But because you've created apnea, you now need to get your tube in, or you need to be able to ventilate the patient by a face mask or a laryngeal mask during the period of apnea, right? Till he comes out of the period of apnea and starts breathing on his own. Or you get your tube in and you can continue to ventilate the patient, right? So once you create apnea, you do face mask ventilation, you do laryngoscopy, and you put your tube in. Right? And once your tube is in the trachea, you ventilate the patient. So then everything is fine. But if you have a problem, either in face mask ventilation or laryngoscopy or intubation, and that's when we call it a difficult airway. And if you have a difficulty either with face mask ventilation or laryngoscopy or intubation, and now supraortic airway device insertion, this has been our traditional definition of the difficult airway. And if you can't do that, you can't ventilate the lungs, you can't get oxygen into the lungs, and that is what results in hypoxia and brain damage. But very importantly, what you need to understand is that if you're in the apneic patient, if you can't ventilate by face mask, if you can't put a tube or a laryngeal mask in, or supraortic airway in, you have a situation which earlier used to be called cannot ventilate, cannot intubate, but what we call as complete ventilation failure. It means you cannot ventilate by any means, neither by a mask, laryngeal mask, face mask, or endotracheal tube. And when you cannot ventilate, that's when hypoxia sets in. So first problem is inability to ventilate. After some time, that results in hypoxia, and that results in death or brain damage, right? So it is very important to understand that because we've created apnea and because we cannot do any of these things for whatever reason, that results in complete ventilation failure or complete inability to ventilate the lungs. That results in hypoxia, which results in a disaster, right? So in other words, this is a sort of situation which we have created largely to facilitate our situation and to keep the patient comfortable, but inability to perform any of these tasks is what we call as difficult airway, and that leads to disaster. Okay. Now, in order to overcome this difficulty, we have resorted to new different types of devices, technology, and techniques, all of which help you to get one of these devices in and get ventilation going to the patient. And that is what keeps our patients safe. 95-99% of the times we are able to put a tube in, or we are able to get a laryngeal mask in. If sometimes if both fail, we are still able to ventilate by face mask, so we are okay. But in the odd patient, inability to do any of these things creates a problem. And fortunately, today we are living in an era where we've got lots and lots of technology and lots of new devices which were not available till a few years ago. And hopefully it is going to make airway management much, much safer. Right? Now, I'm not going to talk individually about each type of device. I'm going to go over the principles of difficult airway management. But essentially, you've got supraortic airway devices. The laryngeal mask was a revolution when it was introduced in anesthesia, because a lot of airways in which you couldn't put a tube could be ventilated using a laryngeal mask. We have different types of laryngeal masks now. And now, currently, we are using the second generation devices like the ProSeal or the Supreme or the Ambu or again or any of those. To make our visualization easier, we've got video laryngoscopes, which have completely changed the way we can look at the larynx and intubate our patients. So a lot of these, this is Dr. Archie Brain who's invented the laryngeal mask, and to me it's one of the most important advances or changes in airway management that we've seen in many, many years, right? So we've got lots of technology which is going to help us manage the airway better. But one of the first steps that we do is pre-oxygenation. And why do we pre-oxygenate? We pre-oxygenate so that we can prolong our safe apnea time. Now, what happens in pre-oxygenation? We replace the nitrogen in the functional residual capacity with oxygen, right? So in the lungs, in your FRC, you've got air, and that is 21% oxygen and the rest is nitrogen. And if you replace that nitrogen then with oxygen, then what essentially happens is your FRC is full of oxygen. Now, if your FRC has air, as in the normal situation, which is about 2,500 mils in an average male, okay, and let's say for the sake of ease, 20% is oxygen, so 500 ml is oxygen. Oxygen is consumed by the body at the rate of 250 mils per minute. So if the patient is apneic and no air is coming into the patient, then this FRC, of the oxygen in this FRC will be used up in 2 minutes. So in 2 minutes, there'll be absolutely no oxygen left in the lungs and the patient will start becoming hypoxic. So if this patient you have to restore ventilation to this apneic patient in less than 2 minutes. Otherwise, you'll be in trouble. When you pre-oxygenate the patient, right, that means you make him breathe 100% oxygen, and you know that your oxygen pre-oxidation is complete when your end tidal oxygen, if you've got a gas monitor, is 90%, right? So that means 90% of the FRC has got oxygen. That means in your FRC of 2.5 liters, you've got 2,250 ml of oxygen, and this will get utilized in 9 minutes. So you have extended your safe apnea interval from 2 minutes to 9 minutes. So you have about 9 minutes in a normal male to get your ventilation going, either by intubation, face mask, laryngeal mask, or whatever. And this is more than enough in most situations. And as we all know that, even if we struggle a little bit in some patients, it's not a big deal and we can get the patients in. In some patients, we struggle much more. And then if we land up in complications, then even these 9 minutes and you can't get the airway going in 9 minutes, then we'll end up in problem, right? Now, the trouble is that 9 minutes is for an average healthy person, right? So, however, some patients desaturate much faster. And these are the patients who have a low FRC. So even if your FRC is 90% saturated with oxygen, if the volume of your FRC is only 1 liter, you still have only 900 ml of oxygen. And then you don't decide, then you desaturate in less than 4 minutes, right? So in other words, if your FRC is low or you're not able to pre-oxygenate the patient as well, then your safe apnea interval is not 9 minutes, it could be much less. And this is a graph which is called a Berumov graph. And I think this is a graph which everyone should be familiar with. This is the oxygen saturation as a time, right, of apnea, when there's apnea. So in a normal 70 kilo patient, it's about 9 minutes. Okay. But right, in someone who's moderately ill, someone who's undergoing perforation peritonitis, who's got an abdominal sepsis, it could be 5 minutes. In a child who's got a low FRC but a high oxygen consumption, it could be you just take about 3+ minutes to desaturate to 90%. And an obese patient, right, an obese patient, desaturation to 90% could happen in just under 3 minutes, even with 87% end-tidal oxygen. So, and if this obese patient is pregnant, then this could be even less than that. So that's why obstetric patients tend to have a very short apnea, safe apnea interval, and the incidence of complications is much higher in obstetrics than in the non-obstetric population, right? So there are situations where even with so-called pre-oxidation with the end-tidal oxygen of 90%, your safe apnea interval could be less than 2 minutes. And then you could be in real trouble, even for what could be a technically easy intubation. If you're not able to do it quickly in 2 minutes, you could land up in trouble. So now we come across this concept where pre-oxygenation, even your pre-oxygenation is not effective, in which case your safe apnea interval is cut down from your average of 8 to 9 minutes. It could be anything of even 2 minutes or less. And that we call as a physiologically difficult airway, because here something is preventing adequate pre-oxygenation, or the pre-oxygenation or your FRC is so low that even if you're well pre-oxygenated, the amount of oxygen in your FRC is going to be low, and you have got a very short safe apnea interval, right? So this is a physiologically difficult airway. And if you can also imagine a situation where, in addition to a physiologically difficult airway, you've got an anatomically or technically difficult airway, you are going to be in serious trouble. So if you've got these obese pregnant patient under an emergency cesarean section, physiologically difficult airway, because of her apnea time is going to be just about 2 minutes, and then she ends up with a difficult intubation, difficult face mask ventilation, difficult laryngeal mask insertion. This patient will crash in less than 2 minutes, and you have a disaster waiting to happen, right? So this is something you need to be very, very aware of, that your safe apnea interval can be extended by pre-oxygenation, but it is not effective in all situations. There are certain situations where you must be very careful, where you have a physiologically difficult airway. These include obese patients, pregnant patients, small children, patients with perforation peritonitis, sepsis. Okay, so these are the patients who you need to be very, very careful about. So the key, of course, is going to be pre-oxygenation, is how you're going to make your apnea intervals safe. And you must make sure you have a tight-fitting mask and at least 10 liters flow. Please don't use low-flow anesthesia for pre-oxygenation, right? Low-flow anesthesia is later on in the process. But for pre-oxygenation, please use 10 liters flow, at least 3 minutes with tidal volume. And you can do, vital capacity breaths for 8 vital capacity breaths for a minute. But the best way to know whether a pre-oxygenation is effective is if you have if you have got an anesthesia gas monitor, is to have end-tidal oxygen concentration of more than 90%. Simple things will actually improve pre-oxygenation. If you give a head-up tilt to your patient, right, then the lungs, the diaphragm goes down, the abdominal contents go down, your FRC increases a little bit, and that significantly improves pre-oxygenation. Definitely in obese patient, the ramp position helps, and you can actually even insufflate oxygen while your face mask ventilation is going on. You can do it. And one of the best ways to sort of improve your FRC is to give CPAP or non-invasive ventilation. And that CPAP of 5 to 7 or 10 centimeters of water can significantly increase the FRC and therefore the pre-oxygenation and therefore the safe apnea time. In the ICU, you can give non-invasive ventilation with PEEP prior to intubating a sick patient. Now, today we are moving from the concept of pre-oxygenation to peri-intubation oxygenation. And what do I mean by peri-intubation oxygenation? So here we've pre-oxygenated the patient, which is crucial, which we must do. But then there is this period of apnea, right? And during this period of apnea, we are doing all our things. You're trying to avoid uh, laryngoscopy, or we are trying to attempt to intubate, or we are trying to get a supraglottic device in. And during this period, while the patient is apneic, we should do apneic oxygenation. So apneic oxygenation during the period of apnea, when you are not ventilating by face mask and doing some other things, we should try and do apneic oxygenation so that oxygenation continues throughout the apneic period, both when we are giving IPPV prior to laryngoscopy and during laryngoscopy, we give apneic oxygenation. Now, what do you mean by apneic oxygenation? You give oxygen through the nose or by a catheter, which is say in the pharynx. You give apneic oxygenation, and that will maintain alveolar delivery of oxygen. Now, a lot of people wonder how a catheter or a cannula placed in the nose, will that oxygen just fill the dead space, or will it actually get into the alveoli? And if it has to improve oxygenation, it has to actually get into the alveoli where it can be taken up by the blood. And in fact, it does happen with apneic oxygenation. Now, how does apneic oxygenation improve oxygen? So this is what normally happens, right? So in this alveolus over here, you've got oxygen and you've got carbon dioxide. Now, oxygen is taken, and carbon dioxide comes from the tissues after metabolism. So oxygen is taken up by the pulmonary vessels, right? And this is then delivered to the tissues, right? And then in the tissues, this oxygen is utilized, like I said, at the rate of 250 mL per minute, and 750 ml oxygen returns to the alveolus after 250 ml is consumed. 200 ml of oxygen of carbon dioxide are produced whether by the tissues during metabolism. Now, all this 200 ml doesn't come back. So ideally, I mean, if you just think mathematically, you should have 750 ml plus 200 ml, 950 ml coming back and 1000 ml consumed. But 750 ml oxygen comes back. But of the 200 ml of carbon dioxide that is produced, a lot of the CO2 is buffered in the blood, right? So at the end of the day, very little, about 10% of the carbon dioxide that is produced in the tissues returns to the lung. So in other words, the amount of CO2 coming back is just about 20 ml. So what is happening in the alveolus is 1000 ml are coming out, going out. I mean, this much oxygen is going out, but much less carbon dioxide is coming in. So there is a sort of a negative pressure in the alveolus during the period of apnea. And here, if you give oxygen at a sufficient rate to go past the dead space, it can actually get absorbed by the alveoli because of this negative pressure in the alveoli. So apneic oxygenation can maintain oxygenation, and that can further extend the safe duration of apnea, which you have achieved with pre-oxygenation. So pre-oxygenation plus apneic oxygenation becomes what we call as peri-intubation oxygenation, and that can also have a potential to significantly improve your extend your safe apnea interval. And the simplest device is the nasal cannula, but you need to give oxygen at a rate of at least 15 liters per minute, which is a maximum you can go on your standard flow meters. So you give oxygen, nasal oxygen at 15 liters per minute, and some people call this a low desat technique, right? So nasal oxygen during attempts at intubation or something like that stand for. But you give 15 liters per minute through a nasal cannula, and that can maintain apneic oxygenation during this period. A very, very important tool we have today is high flow nasal oxygen. So now, like I said, our conventional flow meters give you at 15 liters per minute, but today we have technology which allows you to deliver high flow nasal oxygen during apnea at the rate of 70 liters per minute. And this is called THRIVE. It stands for transnasal. So transnasal, humidified, rapid insufflation, that's 70 liters per minute, ventilatory exchange. All these words are important. And the key in this is you need to make sure you need a special flow meter, which can go up to 70 liters per minute. But very importantly, you need a very efficient and fantastic humidification and warming mechanism, because otherwise your nasal mucosa will slough off if you push in cold, dry oxygen at 70 liters per minute, right? So you need to give this humidifier and heater is a key element in this. And if you can do that, you can provide this throughout the apneic interval. You can also use for pre-oxidation, but the key is that you can give it during intravenous induction and neuromuscular blockade till you secure an airway. And this Thrive looks like this. So this is your special nasal cannula, which is soft, fits in the nose, and allows delivery of heated oxygen uh, through the nose. And you've got this humidifier. You've got this circuit, which is a heated circuit. It's got a wire which goes uh, all through and keeps the oxygen heated, and that's what it does. And above this, you've got your 70 liters per minute flow meter and saline, which water, which is put into the humidifier, right? And there was this very interesting study which was done, which actually popularized Thrive in anesthesia. This was done during ENT surgery. The patients were kept apneic and Thrive was kept on. And what they found is that the median duration of apnea, where the saturation stayed above 90%, was 20 minutes, right? So instead of 9 minutes, you've now got 20 minutes safe duration of apnea. And there were some patients in whom they went on to 30 minutes and some they went on to even 60 minutes. Now, one of the problems with apneic oxygenation is that, the oxygen goes in, but CO2 cannot be washed out, because to wash out CO2, you need movement of air out of the alveoli, right? And therefore, in traditional apneic oxygenation through a standard nasal cannula, your PCO2 rises at the rate of 3 to 6 per minute millimeters of mercury. So in other words, if you have got 10 minutes of apnea, your CO2 could rise by as much as 60. And so normal CO2 of 40 could go up to a PCO2 of 100. And that could be a bit of a problem, right? So that is why even apneic oxygenation has its limits, because the CO2 rises. Happens, right? And that's why if you remember the ventilation, so there's some ventilation going on because the high flow rate flushes the dead of CO2, flushes CO2 out of the dead space. And there is some gas exchange theories for that. One of them is that during apnea, the heart keeps beating, right? And that moves of the lungs when you've got such high flow of oxygen going to the not well understood, but when look I think
Yeah,
I'm disconnected. Can you
I
hear
think
me?
we got disconnected. We can see you now, and you can share the screen
And you
again.
can see the screen.
Yes, we can.
So the rate of rise of PCO2 was just about little over 1 millimeter of mercury per minute. So not 6, but 1, which means there is some CO2 exchange happening. And therefore, Thrive not only improves oxygenation, right, but it also allows certain degree of ventilation, not as good as standard ventilation. So Thrive is an extremely important technique. And can you imagine a situation where you've got 20 minutes to intubate your patient? So in 20 minutes, you can do so many things. Even if you've not got your stuff ready, you can get it ready. You can make a quick phone call. You can even ask someone to drive down quickly from nearby and help you out. You can gather a team. You can do all sorts of things. So, and it gives you peace of mind, right? So if you've got 20 minutes of safe apnea time, it really makes a big difference. And your normal jaldi karo, what's happening, oh my god, I can't do this, you don't have to worry so much. So intubation, instead of becoming a hurried sort of this thing, you can do it little aram se and safely and keep your patient safe. Okay, so this is with this background, I'll just go through quickly over our difficult airway guidelines. Okay, so we stress the importance of oxygenation. And we say, when you say number of attempts at intubation, we say that, well, you can make 3 attempts, but make sure that the saturation is at least 95%. In other words, we have a set of threshold of 95% oxygen saturation to restrict the number of attempts. So if it's less than 95, you quickly move to the next step, even if it's your second attempt, right? Because we know that certain patients have a physiological difficulty and could desaturate faster. And if you do 3 attempts or 4 attempts, like some guidelines allow you, you could be actually creating hypoxia, right? So you need to make sure that your saturation is reasonable. Unlike all the other guidelines till now, we recommend that you give nasal oxygen throughout at the rate of 15 liters per minute. If you have Thrive, give Thrive, but at least give nasal oxygen because that is something which is simple and can easily be done. Now, the British guidelines, the DAS guidelines had a term called CAICO, cannot intubate, cannot oxygenate. And that to me is a very unfortunate term because it says you cannot oxygenate. That means you think you have to wait for hypoxia to set in. You don't have to wait for hypoxia. And we say complete ventilation failure, where you cannot intubate by any means or cannot ventilate by any means. That's when you need to intervene and go to the next step and go to a surgical airway, because ventilation failure occurs first, then oxygen failure. So if you wait for oxygen failure, wait for the saturation to drop, and then do a surgical airway, you're actually sort of delaying your intervention, right? And a cricotherotomy based on a technique which you're most familiar with. We'll come to that. So this is a sort of summary of the guidelines. So the first step starts with laryngoscopy and intubation. If that's difficult, you call for help. So at every stage you call for help. Okay. And okay. So if you're unable to intubate at first attempt with direct or video, and because some people could start with video, continue nasal oxygen, maximum 2 more attempts. So we are giving you 3 attempts, right? But repeat only if the saturation is more than 95%. Mask ventilation between attempts, and very important, in between attempts, right? Change, do something different. Don't do the same thing over and over again. Like change the position, give some pressure, use a stillet, use a bougie, change the operator, do something little different. Maintain depth of anesthesia. If you succeed, you must confirm using capnography. If you fail, continue ventilation with mask ventilation with 100% oxygen. Okay, and then you insert a supraortic airway device. Continue nasal oxygen, use a second generation because they have better mask, better pharyngeal seal, they have better gastric seal, they allow you higher airway pressures during positive pressure ventilation. So I think you should use, if you should use a second generation supraortic airway device. Just excuse me, I'll just take this call. Hello. Okay, sorry about it. You can see the screen now?
Yes, we can.
Yeah. So you put in a supraortic airway device, right? Now, again, if you can't do one, then you try some other device or do something different, right? Now, very importantly, if you got a laryngeal mask in after you failed to intubate, what should you do? One option is you postpone the case. Let the patient wake up, reverse the relaxant, and then do it some other day, right? Or you continue anesthesia using a supraortic airway if that's appropriate for your case. The third option is to intubate through the supraortic airway device. Now, we recommend that if you're intubating through a supraortic airway device, then you should not do a blindly put a tube through. You should do a fiber optic guided intubation through the supraortic airway device. Now that requires skill, it requires equipment, it requires expertise. So if you don't have that, don't do it. But avoid doing a blind intubation for the simple reason you are not able to intubate. You've got a supraortic airway device in. Now, if you put the tube in and it doesn't go in, and the failure rate of blind intubations of supraortic airway, the success rate is anywhere from 40% to 95% or 99, 98%, right? So if you're in the failure group, then you could not get a tube in. You got a laryngeal mask, you put a tube blindly, remove the laryngeal mask, your tube is not in, now you don't have a tube or a laryngeal mask. And repeated maneuvers can actually complicate your airway management, and then even your supraortic airway device may not go in well. So it could create a complication. The best thing is to do a guided fiber optic guided intubation through the laryngeal mask, right? If you don't, then you do one of the other options. And then worst comes to worst, if you can't do anything at all and you have to do the case and something like that, then an option is tracheostomy. Okay. Now, if you cannot insert the supraortic airway device, you're getting deeper and deeper into trouble. Then what you're going to do is you are going to have to do rescue face mask ventilation. So you could not put a tube, your laryngeal mask is not going, patient is apneic, Now you need to make sure you're at least able to ventilate by face mask. And again, you need to make sure you're able to do it. Again, continue nasal oxygen, put airway, nasal, oral, two-handed technique, two-person technique, one person doing a proper jaw thrust, one person bagging the patient. Try and get face mask ventilation going, because this is your last chance. You know, you already failed on the other two attempts. Now, this is something which is very important. You must ensure the patient is well relaxed at this point in time, because very often by this time, the patient has partially started coming out, the cord has started going to spasm because we've been mucking around with the airway. Okay. This is not the best time. I mean, in this situation, even face mask ventilation is going to be easy. So you make sure the patient is well relaxed at this point in time, and then you have the optimum conditions for face mask ventilation. You also have optimum conditions for cricothyrotomy if you're going to go to that step next. So you must make sure the patient is well relaxed at this point in time, right? So final attempt at face mask ventilation is optimal technique and adjuncts. Okay. If you succeed, wake up the patient. Don't fool around, because now after a lot of struggle, you've sort of got your patient safe. Let it continue face mask ventilation till the patient is reversed and wakes up. If you cannot even do rescue face mask ventilation at this stage, you're in serious trouble. This is what we call as complete ventilation failure. Some guidelines call it cannot ventilate, cannot intubate. Some patients call it cannot intubate, cannot oxygenate, but we call it complete ventilation failure. And at this point, very importantly, we say you should call for additional help, because at this stage, it is very important, because you are not probably thinking straight at this point in time. You are worried about how your career is going to go down the drain if this patient dies. You're going to worried about how you're going to pay the malpractice claim, how the patient is going to sue you, what's going to happen to your family, and what's happening to your reputation. You're not thinking of the patient, you're thinking of many other things. So you need a fresh mind, a fresh pair of hands who can think differently, think clearly, and then help you out. Okay, so call for additional help. Right, so this is complete ventilation failure. A situation where intubation, ventilation with a supraortic airway, and a face mask have all failed after the best attempt, even though oxygen may still be reasonably well maintained at this point in time. And this is the point to proceed to a surgical rescue, right? And the surgical rescue is not tracheostomy, but it is cricothyrotomy. And the cricothyrotomy is done because it is very simple. The landmarks are very clear. You don't need surgical expertise. You have kits which you can use. You can have cricothyrotomy kits. And even if you do a surgical cricothyrotomy, it's called as a scalpel bougie tube technique. So you locate the cricothyroid membrane, right? You make a nick, a horizontal nick. It takes you straight into the cricothyroid membrane. Rotate the scalpel so that you widen the hole, put a bougie into the cricothyroid membrane into a trachea, and then railroad a 5 or 6 number endotracheal tube over it, right? Now, the UK guidelines recommend a surgical, but we recommend any technique that you're familiar with. Okay. Now you can do a needle cricothyrotomy, which is you put a needle, a 16 or a 14 gauge needle to the cricothyroid membrane, but you need jet ventilation to ventilate the patient, right? So if you must have a jet ventilator with you at that point in time. When you put a jet ventilator, be very careful, because you're delivering oxygen at a very high flow into the patient, and if it doesn't come out, you're in a problem of barotrauma. And it doesn't come out because there's upper airway obstruction. So make sure that you're doing jaw thrust, you've got an oral and nasal airway in, so that your upper airway is not obstructed. Sometimes if there's laryngeal edema or if there is laryngospasm, again, your gas may not come out. So just give very gentle 3 or 4 or 5 puffs a minute with a jet ventilator, and make sure that the air is all coming out before you give a next jet in. So that's life-saving, but potentially quite dangerous. And we suggest that you do either a cannula cricothyrotomy using one of those kits, or you do a surgical cricothyrotomy. And once you've saved the patient, you need to. The further plan could be continue with cricothyrotomy, convert to tracheostomy, or postpone the case and do it all over again. Monitor and treat for airway, counsel the patient, and document in the records. I think that is extremely important, right? So like I said, that failed airway, where you can't get anything, is failure to ventilate the lungs happens first, then you get failure to oxygenate, and then you get hypoxia. So the time to intervene is when you fail to ventilate the lungs. Some may say it's too early, but if you do it when hypoxia is sudden, it's probably too late. So you should move in for surgical airway when you've got complete ventilation failure at this stage. So this is again a summary of our guidelines, and this is what you do. Now, this is for the unanticipated difficult airway. But there are situations where the airway is likely to be difficult. And maybe at that stage, like I mentioned, doing an awake intubation is probably safer for the patient. Now, when should you do an awake intubation? And again, there are very good guidelines. This is a Canadian guideline and also the new American ASA guidelines. You have a very good clue as to when you should proceed with a difficult airway. So one is, if there is no chance that direct laryngoscopy might succeed. For example, someone who got severe trismus, right? There's no chance you can do a laryngoscopy of any sort. You clearly go ahead with an awake fiber optic. If you also predict difficulty with face mask or laryngeal mask, then again you should think of a awake intubation. If there are physiological issues, right? For example, a severely obese patient, right? So again, you might want to say, I don't want to make him apneic because I've got a very short apneic interval. Maybe I should intubate him awake. Or there are other issues, right? So then these are things which you should consider awake intubation. These are the ASA guidelines, right? So suspected difficult laryngoscopy or intubation with a direct or video laryngoscope, suspected difficult ventilation by a face mask, high risk of aspiration, okay, or increased risk of rapid desaturation. If any of these, if combination of these are there, you should definitely think of awake airway. And if you want to do awake airway, the DAS has got excellent guidelines for awake tracheal intubation, right? So, and they call them the stop method. You need to, maybe you can consider sedation. They say remifentanil, but to me, if you've got a really difficult airway, no sedation is best. But if you want to do in our context, I think dexmedetomidine is a reasonable option. Make sure you've got very good topical anesthesia, oxygenate during awake intubation, even during awake fiber optic or awake video laryngoscopy. You must give oxygen through the nose and thrive if possible, or high flow nasal oxygen is possible, and do your procedure well. Again, you need to be trained well in all these procedures. So this is something you need to practice in a workshop. Same thing with cricothyrotomy. Cricothyrotomy is not something you can do on a routine basis. You need to practice in workshops and animal models and so on. Fiber optic, you can do it if you've got the facilities and practice in even normal patients, but you should practice even in workshops and stuff like that. So that's where all these things are very important. And be sure that you're able to manage complications, especially make sure the patient doesn't get obstructed. Make sure you have got the facilities to manage local anesthetic toxicity, right? And again, don't keep on doing these things, abandon if you are not able to do it. I think I'll skip these two slides for the time being. And after all these guidelines, there is a currently project which is going on called PUMA, or the project for universal principles of universal management of airways, and they'll be coming out pretty soon with their sort of guidelines. Very importantly, we need to understand that while we all may be very good at techniques and technology and use of laryngeal mask and fiber optics and this and that, when confronted with a difficult situation, our mind doesn't work well, and some of the things which we can do very well in a normal situation, we tend to do badly when we are confronted with a problem. So cognitive errors, right? These are the things which actually give rise to problems. You don't think clearly, you don't do things which you're supposed to be doing, you keep doing things which you should not be doing. So most errors are mistakes in thinking. And we really need to understand the psychology of why we do what we do. And that's a separate issue altogether. And that is why calling for help and having additional help or calling a new person in takes care of some of these problems. But some of these problems can be alleviated by training, by repeated simulation, and also even in a difficult situation, your mind is sort of configured to what you have to do. Guidelines help you, but guidelines are not everything. The guidelines provide a structured tool to something you can train with, right? But they can't prompt you during a crisis. So during a crisis, you can't, hey, let's get the guidelines, let's get the IDA guidelines and see what is the next step. Right, so they are useful for teaching, they're useful for debriefing after a difficult case and that kind of things. One thing which can be used during a case, right, as a prompt during a crisis is what is called a vortex approach. And essentially what vortex says is that, you have to go to the green zone where you're safe, blue, and there are three tools. One is the laryngeal, the face mask, the laryngeal mask, and the endotracheal tube. You can use any of these. You can use adjuncts like bougie, stillet, that sort of thing. You must give oxygen, and 3 attempts at any of these, and if any of these fail, you move to any of the other techniques and you try and get your gap vaccine. So maximum 3 attempts at each lifeline. So these are lifelines, tube, laryngeal mask, and face mask. At least 1 attempt should be by an experienced clinician. And as you get worse and worse, you move out of the vortex. As you get better, you move into the green zone. So that's one of the ways in which you can sort of conceptualize it. I can't conceptualize it very well, but some people do. So that's one more thing that you can consider. Okay, so I think I've stopped here on management of difficult airway, and I'll be happy to take questions. Thank you very much for listening, and thank you for asking me to speak.
Thank you very much, Dr. Divatia. Dr. Divatia, how often when we have a difficult airway and supposing we have an access to the Thrive with us in the operation theaters, so would you like that to be as a routine to put up like an anticipated difficult airway, put in a Thrive, give them a high flow oxygen so that we are pre-oxygenating the patient well? And so should that be like a part of the routine if it is available?
Just 1 minute, Kalpana, there's some. Sorry. Yeah. So I think that's a very important point that you raised. So Thrive is best when it is started early. Thrive should not be started once you've landed in trouble and the patient has started desaturating and that kind of thing. So if you are expecting a difficult case, like say an obese patient or someone like that, you should probably start right from the beginning, right? So that you pre-oxygenate well. You can either pre-oxygenate with Thrive or Thrive plus face mask, but make sure that the FRC is high by face mask ventilation before your Thrive is applied. So you should apply Thrive if it's available well in advance and not as a rescue. Thrive doesn't work as a rescue. Thrive works in a elective situation. Secondly, when you give Thrive, you must make sure that the airway is patent so that there is, because otherwise the gas will not get in. And you need to make sure that the patient is a little head up so that especially when a patient is obese, overweight or something, your FRC is high. That is the best sort of optimum conditions for Thrive to work well.
The other thing I'd like to ask you is about the cricothyroidectomy that we do, which is like non-surgical, which we would be doing it in case it's an emergency situation, whether it's the ICU or the OR, till our surgical colleagues come in. The kits that we use, is that the one with the guide wire? Or, I mean, could you just enlighten us a little bit about that?
Yeah, so there are various types of kits, right? So one of the kits has a guide wire. So you put a needle, you put a guide wire, and then you have the tube which, or a dilator and a tube which goes over it, right? There are some which don't have a guide wire. So you just put the trocar and the tube is directly put over it. So and there are some which have some devices which prevent you from puncturing the posterior wall of the trachea and so on. So the important thing is, these are the things which you should have practiced with in dummies before, and not to be used for the very first time and open the instruction kit when you're in a crisis like this, right, in the instruction manual. So you need to have practiced these, and these should be available in your OR all the time, or wherever you're, the ICU or emergency department. So I think that is the main problem. So that is why some of the people are advocating that we should be trained in the surgical technique, that is a scalpel Bucci tube technique, because this is available in every OT. It is available all the time. You don't have to hunt around for special equipment. But what we do have to do is we have to train. Now, unfortunately, cricothyrotomy is not something which cricothyrotomy karega. Aaj tube nahi dalega, cricothyrotomy karega. You can do it for laryngeal mask or fiber optic intubation or something like that. But here you have to actually take part in workshops, go to workshops, do it on animal models in some of these workshops, do it on dummies, get these trainers, get that this thing and do it. It's not very difficult, but it's you need to do it on a dummy before you actually go down and do it on a patient. So the problem is it's something you don't have human experience of before you sort of, sometimes you're doing it for the very first time, but at least you would have done it in dummies and animal models before you do it. So
what is your view on jet ventilators?
yeah, so jet ventilator, they're a very attractive concept conceptually, but so, and the simplest thing for anesthetist would be to put a wide bore needle into the cannula into the cricothyroid membrane, 14 gauge or a 16 gauge cannula, and connect a jet, and that will save the life. But you have to be very careful when you do jet ventilation. One is the jet ventilator must have a regulated airway pressure. So you have commercial devices now called ManuJet, which actually help you regulate the pressure. But you need to make sure again of 2-3 things. One is that the upper airway is patent, because the gas is going to come out through the upper airway, which you blast in at a very high pressure. So you need the upper airway to be patent, which means you can either jaw thrust or a nasal or a oral airway. Sometimes, like I mentioned, during attempts at intubation and laryngeal mask, you get a little laryngeal edema or laryngospasm, in which case the upper airway is not patent. Even if you can open the pharynx, the larynx may not be fully open, and then there is a potential for barotrauma. The third thing is, remember, all you want to do is maintain the oxygenation over here. And the problem is when we are in a crisis, when something like that happens, we tend to go fast. Either you bag very fast or you jet very fast. So you should not jet fast at all. You should just give one jet, that to a small jet, wait for the chest to just rise, then allow time for the gas to come out. You can either listen for the gas coming out or you can feel the gas coming out and then give the next jet. Because otherwise there's again a risk of barotrauma. Some people recommend that you put a second needle, a smaller needle in the cricothyroid membrane as a vent, so it sort of vents off some of the pressure. So that's one more option. Okay, but remember that so these are some of the things you need to be careful when you jet ventilate. There are now a new device called a vent train, which pushes in and sucks out air. So maybe it's a little safer, but I've not used it, so I can't really say. But I do know it's there. But so one thing I need to tell you, that very often not very often, but we've seen that when you come to the stage where you're just not able to ventilate, just not able to intubate, not even face mask, your hands are shaking, and sometimes you can't even get a needle into the cricothyroid membrane properly, right? So your needle will fall and something will happen, and you can get complications because you'll go into a wrong plane or, in the wrong area. So it sounds simple, but just think of the situation that is there at that point in time. So again, it's important that you get a fresh pair of hands or a fresh person over there, call for additional help. So that's the take on jet ventilation.
There's a question in the chat box asking, what is the role of combi tube in difficult airway?
So combi tube is another device which you can use in difficult airway. And again, the good thing is you can be either in the trachea or you can be in the esophagus, and you can get ventilation going. Again, that's a device which is not commonly available. I mean, I've not seen it in any of the many OTs that I've been in many institutions. It has been used in emergency department sometimes. Secondly, there is a potential for trauma with the combi tube. But if it is available in your OT, and if it is a device which you're reasonably familiar with, I guess you can use it. There's no bar to using it. You can think of it as another supraortic airway device, right? But you just need to know how to use it, and you can use it either from the tracheal lumen or the pharyngeal lumen, and one of them will work, right? So that's what we'll do. So that is a potential option. But, again, very often we land up, why are we not able to ventilate patients by face mask when you are able to initially ventilate them? I mean, that is the key. You started off being able to ventilate by face mask, then you tried to intubate, then you failed, then you couldn't do a supraortic. Now, why you're not able to intubate by face mask? Because once all this has happened, once you mucked around with the airway, you've caused a little bit of trauma, there's a little bit of laryngospasm, a little bit of edema settling in. That's when ventilation starts becoming difficult, right? And in that situation, even if your combi tube stays in the esophagus, the main lumen in the esophagus, your ventilation through the pharyngeal openings may or may not be very effective. So I think that is what you need to understand. And that is why you need to quickly move towards securing a surgical airway. You can try it if you want, but it may not be effective, just like a supportic airway. But so the key thing is you recognize there's a problem, it's not happening, don't keep persisting and move on to the next step.
Is it
Kalpana, can I ask one thing?
application of Thrive in pediatric patients?
Yes, so in fact, Thrive was high flow nasal oxygen was used in the management of respiratory failure in infant neonates and infants for a very, very long time. And the adult community actually caught on to it very late. And in adults, it was initially used in respiratory failure in the ICU. And the anesthesia community actually caught on it very late. So Thrive is a very relatively late development in the history evolution of high flow nasal oxygen. So yes, you can use it in children, although I am not going to comment on pediatric anesthesia. Okay, but I do know that the high flow nasal oxygen can be used in children. And roughly, I think 1 ml per kilo is the
Flow rate. And what are the risk of aspiration and regurgitations with Thrive? But I mean, we were discussing this in an elective anticipated, but what about an unanticipated, a full stomach patient? So then what would be the risk of aspiration regurgitation?
So again, if it's unanticipated, you've not given Thrive, then you are in a, it may not be very effective because you should start it right from the beginning. But let's say you got bag mask ventilation going and then you start Thrive, it's reasonable to start Thrive at that point in time. So the risk of aspiration and regurgitation is, I don't think is much higher, although I can't quote you any study or literature on that. I don't think it's much higher than that with bag mask ventilation. So if you're doing bag mask ventilation, and the Thrive, if the mouth is closed, with Thrive, you get about a 5 CPAP, right? Because there's a very high flow in, which impedes the passage of air out. And so you get a small airway pressure. But when the mouth is open, then there's a free egress of air, and then you don't really get Thrive. But if your upper airway is not patent, then your 70 liters, a lot of it is going to go in the esophagus. And then there is a danger of aspiration regurgitation, just as there is a danger of face mask ventilation. Whatever you blow is going to go into the stomach, and then you're going to have a problem. So the key in Thrive is to make sure your upper airway is patent.
Jiggy, this is Kalpana, 1 second. Jiggy, this is Ketan here.
Yes, Ketan, good morning.
This was my question pertaining to the OB situation. See, you talking about a planned intubation in OB where you're anticipating difficult airway and you start with a Thrive. I was just asking what are the risks, because in OB you can never have a empty stomach, So are there any studies or are there any kind of this thing about Thrive in OB situation?
So there's not that much data on Thrive in OB situation. Okay, again, for the same concerns that you expressed, that it has not been widely used in OB in obstetric patients. But if you're giving general anesthesia to someone who is pregnant, or you're doing a Caesar or whatever it is, even now the guidelines allow you to give gentle IPPV to a pressure of about 20 centimeters of water.
Correct.
During the apneic interval, right, when you're giving face mask ventilation. So if let's say you fail the first time, you can give gentle IPPV and then start Thrive. I don't think it's a problem, but if you're asking me for literature, I'm not very sure of that literature in that situation.
Right. Okay. Thank you.
Alka madam, please unmute and ask your question. Alka madam? Okay, meanwhile, anybody else till we get Alka madam again? Anybody has any questions to ask? So in the chat box, there is one, if there are any special concerns about dealing with difficult airway in emergency rooms, trauma victims, and critical care scenarios.
Yeah, so I did not deal with this part because I've focused on anesthesia. But in the critical care unit and in emergency room, there are the strategies slightly different, mainly because patients often come with respiratory failure because of hypoxia with respiratory failure, and in these patients the FRC is reduced, right? And therefore apneic you need, so the long and short of it is, if possible, non-invasive ventilation for pre-oxygenation with PEEP and 100% oxygen and pressure support, high flow nasal oxygen during the apneic interval. Be very careful that you take care of cardiorespiratory instability. There was a study recently published called the Intube study, where they found that almost 49% of patients had cardiovascular collapse after intubation. That's because they use drugs like propofol for intubation, right? So in these patients, use ketamine or etomidate if possible for intubation. Make sure your patient remains hemodynamically stable. Either use fluids or vasopressors to maintain hemodynamic stability during the intubation procedure, use a video laryngoscope, and the rest of the things are there. But mainly you need to focus that the patient doesn't develop hypoxia, because FRC may be reduced and pre-oxygenation is not very effective, and there is a risk of cardiovascular collapse. So your scenario needs to be modified around those kind of scenes.
Alka, madam?
Hello, Dr. Divatia, this is Dr. Alka.
We can't hear you well, madam. Can you be a bit loud, please?
Yeah, this is Dr. Alka Halbe.
Yes, good morning, madam.
Yeah. I just wanted to ask you, if you treated medico-legal, see, in our hospital, there are only 2 areas where we have jet ventilator. Actually, Kalpana was asking because the whole discussion is going on in our institute. So is it mandatory we have to have in every theater or ICU or something? If it is not there, will it be medico-legally, we will be affected?
Madam, I cannot speak for what the judges might say or what a smart lawyer will do, but you should have something in your OT to do a surgical airway. Right now, whether it is a needle cricothyrotomy or whether it is a cricothyrotomy cannula kit or whether it is a surgical cricothyrotomy, right? And I would say that in every OT, if you say that we had a bougie, we had a scalpel, and we had a 5 or 6 number tube, you can say we had the equipment ready for a surgical cricothyrotomy, so you were safe, even if you did not have a jet ventilator. Let me put it this way. If you put in a jet ventilator, a needle, and you gave jet ventilation and there was barotrauma and a pneumothorax and the patient died, you would still land up in medical legal trouble, right? So let's not get into the medical legal things, because the circumstances can be twisted by smart lawyers to suit their this thing. But as far as the safety of our patients is concerned, we must have something to do a surgical airway. If you and you must have had at least some training in some workshop or something, so that you're at least familiar with the steps of the procedure and know what it feels like to puncture the cricothyroid membrane with a scalpel, turn it around, put a bougie and a tube over it.
The question is that what is the role of ultrasound? Because what they say, this patient, because I deal.
Alka, madam, you are not audible at all. Is it possible for you to come a little closer to the screen?
Yeah.
No, yet you are not audible.
Can you hear better now?
No, madam.
Oh, I'm so sorry. What to do now?
Madam, you can type your question otherwise.
Is it better?
No, madam. Type your questions.
Okay.
There's another question which asks for the role of ultrasound.
Yeah. That is what I wanted to hear.
So the role of ultrasound in what? So one is that maybe a role for ultrasound in there may be a role of ultrasound in diagnosing or just give me 1 minute. There's some fellow just from Yeah, sorry. So ultrasound you can use to assess the airway. Ultrasound you can use to locate the cricothyroid membrane and the trachea, and you can use ultrasound to confirm that the tube is in the trachea by looking at the bilateral lung slide, right? So there is a role for ultrasound, and so, but I would just say that the role of ultrasound is largely in the elective setting, not in the emergency setting. In the emergency setting, to do an ultrasound, let's say, and you would do it because you had difficulty in locating the cricothyroid membrane, right? So to do it in that setting in a difficult patient, and to cannulate the trachea using the cricothyroid membrane, again, is something which requires a lot of practice and a lot of expertise, right? And you should have, again, good training in ultrasound to be able to do that, definitely in an emergency situation. So in an emergency, the role of ultrasound, except to maybe confirm tracheal tube placement or diagnose pneumothorax, is okay. But to locate the cricothyroid membrane may be a little challenging. If you have a difficult case and you're expecting a difficult case, yes, you should do an ultrasound and mark the cricothyroid membrane in advance, so that you can where to look up if in case there is a problem. But in the heat of the moment when things are going wrong, to do this thing is probably a little difficult.
I think if there are no more questions, we may call it a day. And I think, Dr. Divatia, I thank you for this time that you have given us with great pearls of wisdom that you have shared with all of us today here. I'm sure the residents and all the delegates who attended might have found it really very useful. I thank you once again for giving us today morning a few hours with us. Thank you so much.
Thank you, Dr. Kalpana. Thank you for inviting me to speak to all of you. It was a pleasure. Thank you so much.
Bye-bye, everybody.